into the monthly Suitcase travel plan. So I'm sure this is a new voice to everyone. Sam is just not here today, so I'm standing in Sam's there. I'm Dr. Cecile Ulifi, but I'm also working at Travel Doctor Corporate, and we'll get started. So basically, everyone knows that this is the monthly Suitcase Club in conjunction with Sentinel. So just a quick reminder of why we do this is basically the Suitcase Club is the only springboard for travel in South Africa that we're basically using. We're doing this in conjunction with Sentinel, which is a global network of travel health centers reporting back on ill-return travelers. So anyone who actually gets exposed to ill travelers that are coming back and are presenting with interesting symptoms or interesting diagnoses, please remember to actually submit to the Sentinel. And I will show you the details now. So you can either email it to Sentinel or you can phone in and skip the case details to us. So the monthly Suitcase Club is obviously hosted by Travel Doctor Corporate and our travel doctors. So it's hosted at the Baobab Room at Fire Station Rosebank. So next time, if you are able to come in person, please do, because we always have nice treats. And you can come in and see our Nando's. Yeah, we have nice views, Nando's, and great company and coffee. So also, we just a reminder to any GPs or anyone else that have people who come in and asking about shingles vaccines and malaria prophylaxis for children. We do import this Shingrix vaccine under Section 21, as well as mefloquine for pediatric malaria. So just remember that. So without further ado, we have our presenter. We are currently speaking about sleeping sickness, which is a wake-up call for everyone. So Dr. Shoul is an infectious disease specialist at Milk Park Hospital, and his CV is too long to read. And we all know him very well. So
I'm number one, refer Dr. 2.
So I'll give over to him.
Thank you very much. So this talk is based on a couple of patients that came to our hospital a few weeks ago. So they were literally hot off the press and figuratively hot off the press. So they are father and son team. So we got father and son admitted, who are based in the Cayman Islands, and I must confess I had to revise where exactly that is, even though it's one of the provinces of South Africa, along with Dubai. So we see it's in the Caribbean. It's a group of islands, and we're going to zoom in on the main one in a moment. And the main island is the Grand Cayman Island, and I've only really included this part of the map because parts of the island have such spectacular names, like Rum Point and Gun Bay. So that's the sort of Grand Cayman Island where the famous sort of banking industry is based. There are a number of other smaller islands dotted around. Obviously, a lot less residential exposure that side. So these two guys came from the Cayman Islands, and they were on a road trip that they flew into Johannesburg. They're originally from South Africa. The father, who's in his late 60s, is originally from the Midlands, and they moved to the Cayman Islands about 15, 20 years ago. The children originally grew up in South Africa, and the family moved over to the Cayman Islands. And so they started their trip in Johannesburg, and I'm going to show you the magnificent itinerary in the next slide. But it basically was a road trip, a father-son road trip that went through from Joburg across into Namibia, then to Botswana, the Delta, up to Zambia, and then from Zambia to Zimbabwe, which was where they ended up in a hospital. So the sorry, that doesn't project very well, but the son who's in IT, when I asked him for the itinerary, mostly for the geosentinel survey, he gladly obliged with an amazing Excel spreadsheet. And so this, right at the top, you'll see South Africa. Then they cross the border into Namibia, and they sort of detail almost every day the date, where they are, where they were staying. Sometimes it's a resort, sometimes it's a tent, sometimes it's a campsite. Then there were a number of other columns that weren't ready for our view. So this was it was just logistical stuff. But the main dates are what's important to us. Namibia, they sort of drove up to Natasha, then from Namibia in July, then they go across into Zambia, and in Zambia, and I just want you to, into Zim. Just want you to sort of keep chips on the dates. So there's Kariba, there's a bit of houseboats, which really sounded quite magnificent. Martin Pools, which is, in my mind, only infamous because of Lucille's talks related to this topic, but also apparently in all the travel brochures. Absolutely beautiful. Then in Zambia, starting off in Lusaka, going through to South Luangwa, then right at the bottom it's cut off, North Luangwa. Let's see if the next thing comes up. Yeah, South Luangwa, and then crossing over into Harare by the middle of September, which is when they started to feel unwell. So the middle of September. We'll go into the details of the timeline in a moment. So this referral started early in the morning, but the morning started a lot earlier for a lot of other people who were maybe checking Facebook at the time, where these two guys were admitted to a hospital in Harare. And I say to credit of the doctors in the Borrowdale Hospital. They suspected trypanosomiasis. It was diagnosed on the smear. I think these guys had spent one night in the hospital in Harare. And there was great concern because of access to drugs. The father was very ill, and there were a lot of discussions about whether to get the drug over to Harare or whether to get these guys to Johannesburg. And through the most incredible network that has extended far and wide across oceans, literally, and continents, they ended up with us at Mill Park, and they were flown to us on the 19th of September. So both the father and the son were diagnosed as having trypanosomiasis, but I'm just going to present, just for time's sake, the case involving the father. So they had been on this trip, and their symptoms had started in the middle of September, about the 15th, where the father noticed rigors. He was quite weak, he was a bit drowsy, normally a very fit, active, lust for life sort of a guy. Became very weak, couldn't walk. He had fevers and sweats, nausea, vomiting, shortness of breath, coughing, and what was a concern was a few days later, within a short period of time, he started getting confused. In terms of his background history, nothing major. I think these were the only two people on the island not in the banking industry. And he had gone over there to run a set of recycling companies a number of years back. And he's otherwise reasonably healthy, only on a statin. And by the time he came into the emergency department, so they were flown from Harare to Johannesburg, and they came through the emergency department. He was incredibly ill. Had a spectacular tachycardia going at about 130, 140, temperatures up to 39, clearly distressed, agitated, pulling on the oxygen mask, quite agitated, but able to give a history reasonably lucid. But just this sort of feverish agitation that it looks like it can turn cardiac and abdominal exam. Remarkable, but what was a concern was that his respiratory status was a worry. He was quite tachypneic, thankfully keeping his oxygen. SATs okay, but did look like there was acidotic breathing. And of note, not the greatest bite that we've had, but it's been a few years, so we'll take it. So this was from his left lower leg, and they give a very, very clear history of when and how and where they were bitten. Very painful bites. They remember exactly where they were. They were, as the sort of general exposure story goes with these cases, they were in the back of a Range Rover in an open vehicle, and they were actually bitten in the vehicle. They very certain that it was from, I think it's the North Luangwa. And so this was the only shanker. The son, they didn't have any notable shanker. So this was on Dad's lower leg. And the admission bloods with us showed a profound lymphopenia. And platelets were low. Malaria smear and antigen both negative. Iron R was 1.7, which is quite an ominous sign in someone who's not on warfarin. So just a spontaneously elevated iron R was a worry for us. Hyponatremic, creatinine elevated, very, very high CRP. And of note, his liver function tests showing that his total bilirubin was up, and his ALT and AST were elevated as well. And so I just thought it would be a good time to refresh our memory on the broad differential of fever and thrombocytopenia that we encounter in patients who are flown back to us. It's a broad differential, sometimes quite an exciting, maybe too exciting differential, including some sinister viruses, but for the most part, the common ones that we deal with are obviously malaria, gram-negative infection, salmonella, rickettsia, the tick bite fevers can have thrombocytopenias. And I must say, over the last year or two, I'm definitely seeing more and more arboviruses, so more dengue, and not so much West Nile, but so just the viral causes for fever and thrombocytopenia. And then it's always worthwhile remembering that there are a long list of non-infectious causes as well when dealing with fever and thrombocytopenia. But in this situation, the travel exposures, the geographical and epidemiological factors all made sense in terms of this being something infectious, and the doctors in the hospital in Harare, I must say, it's really excellent that they noticed that this clinical picture, which, if you look through the presentation, you look at the symptomatology, you look at the blood work, it really 99.5% of the time would be malaria in terms of where these guys had traveled to. And obviously the malaria with the doctors in Harare were negative, the malaria smears were negative, and they picked up the trypanosomes. So that really for us, when we hear of these patients who are north of our borders with this type of a clinical picture and the initial malaria testing is negative, makes us think of either of a number of the other differentials shown. So these two guys had already come with the diagnosis, but on our initial investigations when they came in, besides for the ones that I've just shown you, these were images that John had sent me, and the image on the right is from the patient that we just presented, and his son, who was thankfully stable. He was clinically more stable, but still had markedly deranged renal and liver function, but was a lot more lucid and compared to the father. And you can see on the thick film just the incredible burden of parasites on the right, so on the left, but I think
That's quite hectic.
yeah. So I think John had calculated the parasitemia. I don't think there's a percentage or anything, but it's
we work it out per volume. So the father had about 48,000 per microliter. The son 28, I think, or around about there. So quite a lot less. But you don't need a lot to make you very ill.
yeah. Have we seen this this number before?
Patient who died.
We've seen
The
worse.
one from Malawi.
We've seen worse.
Yeah, it was your patient.
Yeah, I can't remember
But it's a
his
sick
split.
film.
Yeah.
Yeah. But it's hectic.
Yeah. So just a bit about the East African trypanosomiasis. So you see on the right-hand side of the map the lighter coloured countries showing the reported cases. The red on the left side, that's West African trypanosomiasis. That's for another time. But transmitted by the Glossina fly. We're going to see an image of that in a moment. And it's mostly related to, well, the flies prefer to feed on wild animals or the domestic animals, and animals are the reservoir, mostly cattle. This map just shows the cases reported, and we see the number of travellers that were reported in. Sorry, these are people who live in the different countries, and we see the difference in the incidence between the East African and West African. And there's one spot, I think in Uganda, where there's a bit of overlap between the two. So this was from a paper that John Lucille put together of the cases that had come through to South Africa over the years, and we see some of the hotspots in sub-Saharan Africa. And these are, I think these were mostly travellers. There were some lodge owners, hunters, some military personnel, and we see how the map sort of nicely tracks the initial map that we looked at. So when we hear of someone being sent through that's come from one of these places, we already have our sort of feelers out, sort of waiting expectantly that this might be something trypanosomiasis related if the malaria testing is negative. It's a unicellular organism. It's covered in a glycoprotein coat, which helps it evade the immune system. So there's lots of pathogenic variation. There's a number of genes involved with it. So you can see the image on the left-hand side where it's extracellular parasite compared to malaria, which is an interesting parasite. And this is the vector. So both the males and females feed on mammalian hosts, and the number of flies that apparently carry the transmittable infection is very, very low. So
Is that the same as a tsetse fly?
yeah, that is the tsetse.
Okay.
And what is the tsetse? It's clearly some kind of nomenclature there. Is it a local word for?
That's the scientific name.
What is it?
Glossina.
Yeah, but the
genus.
tsetse is,
Tsetse.
yes, it sounds like a,
It's an African name.
We look up what it means.
It actually
Good.
sounds like a fly that's fluttering.
yeah, it would have that.
Yeah, that's yeah. So sorry, I've included the boring name here, but often the patients will report the bites. They remember it clearly. There's a lot of reports about the bites being painful, and often the bites are multiple. Someone did ask me whether it was the same fly that bit the father and the son. I obviously can't answer that.
Yeah, probably. It's probably.
It was a valid question. So the sort of characteristic feature of East African trypanosomiasis, which is one of the big giveaways, is the chancre, where there's local multiplication of the trypanosomes at the bite. And the majority, certainly the majority of the cases that we've had here, and I think the ones that John and Lucille have seen over the years, have had this on presentation. So this is in travellers versus those who are in endemic countries where the chancres are a lot lower. And there's two main stages. The first stage is the particular endothelial infiltration, where there's the lymphadenopathy, febrile episodes, the parasite is in the blood. This can go for a few weeks, and then there's the dreaded second stage. And we're going to talk a little bit more about this when it comes to management in a moment, where there's a parasite penetration into the central nervous system, and that's where the sleeping sickness name comes from, where there's a severe neurological involvement, more often and more easily seen with the West African trypanosomiasis, which is a much longer clinical course. In the East African trypanosomiasis cases, the presentation is far more acute. The neurological features that we've seen are not so much patients that are sleeping, but very agitated, very confused, and we've had one with seizures. This next slide is really just a summary of some of our cases that we've had over the years, and you can see the geographical exposures. So Zambia, Malawi, being the commonest from the last few years. A lot of tourists, guys working in anti-poaching units, people working in lodges, volunteering with animals, and I've included some of the blood work so that you can get an idea of the multi-organ involvement. I don't think it's necessarily from the parasites themselves, but these patients have inflammatory response, lots of hemodynamic changes, tachycardias, BPs all over the place, they're sweating, they're using fluids like crazy, and so very often these patients have renal dysfunction. You can see the creatinine in a number of the patients was elevated, and the transaminases in a lot of the patients. In fact, in almost all of them were abnormal. And then there's a set of pictures of all the different shankers that we've had over the years. So what's interesting about, one of the many interesting things actually about trypanosomiasis is that it's on the WHO list of neglected tropical diseases. It's still as long as it was a number of years ago, despite a lot of effort. But hopefully, as we'll see here, there might be some movement from the trypanosomiasis side. So this is from a recent guideline that came out a couple of months ago, which has this graph showing the number of cases over a 20-odd year period. And you can see that the West African trypanosomiasis is by far more numerous, and the East African trips always been a lot lower, but we see that the numbers now are really incredibly small. I think it's well below 1,000 a year. 100.
Sure, someone missed.
And this really is I think, a very exciting graph, because firstly, we can see the amazing progress that's been made in the last 20-odd years. But also, it's, that last bit of the tail, as we've seen with polio, is probably the hardest, one of the more challenging parts of dealing with these neglected tropical diseases. And this is taken from an article that deals with not just trypanosomiasis, but neglected tropical diseases generally. Just the number of different interventions needed, the number of different sectors that have to get involved, the coordination that's needed, and it's really quite incredible what's happened with trypanosomiasis, considering the wide geographical area that we're dealing with, the fact that we're dealing with countries that have a great amount of political instability, very fragile healthcare services, and so taking all of these factors into consideration, it's really quite incredible to see a graph like this, considering what sort of odds have been stacked up against this. This was I thought, a great picture taken from the guidelines of a chap who's in DRC working in a little field clinic doing diagnostics. Your diagnostics.
Oh, yeah.
Yeah.
Yeah, amazing. On my picture.
This is from a recent article just on the different diagnostic strategies. So in South Africa, we have the top one, the examination of wet blood, so a smear. We see it's got great specificity, but the sensitivity is a bit iffy. There are other tests, like agglutination tests that are used for surveillance on population levels. And then I've also included this just to show you the PCR, which hopefully John will tell us a bit more about maybe at the end, where if you look at the limits of detection, it's really quite incredible how few parasites are needed for the PCR to flag positive. John, anything to add while we're here?
No, just to point out that it is available with acid NICD.
And also just to mention that the card agglutination is for West Africa. Yeah,
Okay.
it's not for East Africa.
So as we saw in one of the earlier slides, that the thick smear allows us, or allows the laboratory to assess more volume of blood. It's a similar procedure to the thick smear that's done for malaria, where an eagle eye view of a greater volume can be assessed. And then the thin smear, which allows the single cell layer of red cells to be analyzed. Now, where's my
Wonderful.
It's, you almost feel bad enjoying this
I
video.
know.
So, really
Very good.
such a guilty pleasure. But, so our two patients underwent a CSF examination quite a few days after their admission. There's differing opinions. We've always given the serum to try and clear the peripheral blood before an LP is done. But as happened with the father, we ran into trouble with his platelet count, where after he received his first dose of treatment, his platelets absolutely plummeted, and we sort of missed the initial window to do a lumbar puncture, so we had to wait over a week to do it because his platelets came down to single digits, and we had to hang in there for a few days before doing lumbar punctures on both the patients. But there are obviously criteria involving the microscopy, looking at the cells, looking for trypanosomes, and these supposedly classic marula cells that you see on the bottom right-hand side. So our two patients underwent lumbar punctures. The son had a lymphocyte count of 17, but already by that time he was feeling very, very well. And he had 17 lymphocytes on his spinal fluid, and he had slightly raised protein. And that spinal fluid went off to the parasitology lab at the NICD, where a PCR was conducted on that spinal fluid, and I must say we got the result within hours. It was absolutely magnificent. It really made such a huge difference.
And it was positive.
It was negative. So it's incredibly reassuring for doctor and patient alike to have that result so quickly, and also, as we'll see in the next couple of slides, the management really changes quite significantly, depending on that result. So this is from what is now recently out of date. recommendation on the treatment protocol, where for stage 1 suramin, which is for the parasite in the blood, but it doesn't cross the blood-brain barrier. So stage 2 would be Losapro. Thankfully, I've never given it, but I think Seal, John,
It's
Kim,
arsenic, and it causes encephalopathy.
It can do
It can.
Okay.
And in 50% of those, it's a fatal one.
50%.
Yeah.
So you're only going to give it if they're going to die anyway, type.
No, we can do better now
yeah, that's coming.
in some patients.
So suramin, within an hour or two of our patients arriving, we were able to give them the test dose, and then the first dose within a short time after their arrival. And I must say, for the most part, our experience has been quite positive with suramin. It's a life-saving drug. It does have a number of side effects that we've now realized we anticipate and counsel the patients about the rocky few days that they may have after the dose. There's renal dysfunction that's a cause of concern, and we've had a few skin reactions, and I must say some drug-related pyrexial episodes. I think they're drug-related pyrexial episodes. We tested all sorts of other things, and nothing comes up, and then eventually settles down. So, the old, and the other thing I read just last night about suramin is that it was first used in 1920.
Yes.
So unfortunately, we missed its 100-year anniversary. We were a bit busy with something else at that time, 2020. So Losapro, as Lucille mentioned, thankfully I've never had to use it, but in all the guidelines, in all the articles, there's this awful encephalopathy that has a very high mortality rate. It must be the most awful thing to deal with. You don't know if this is something from the drug, if this is the infection, if this is something related to the patient. You don't know which way is up when this encephalopathy occurs. And there is an attempt to get preemptive steroids, which may alleviate some of the potential side effects from using the drug. But thankfully, a couple of months ago, there was a new guideline that was released. It's a really, really excellent guideline. It's a nice, easy read, good summary of trypanosomiasis, West and East African trypanosomiasis. And it mentions fexinadisol, which is approved for East and West African trips and for stage 1 and stage 2 disease, which is quite a big jump compared to where we've been. And the other thing is that it's an exclusively oral regimen. For West African trypanosomiasis, over the last few years, there has been one of the drugs is now oral, but there is still an intravenous. There was an intravenous and an oral combination for West African trips, but there's never been an all-oral regimen. So that's really exciting, and we're waiting to get our first few doses. But it's not without its issues. It can't be crushed, it can't be broken. I'm not sure, Lucille, about intubated patients or nasogastric tubes or whatever. You know.
So it has a very limited trial. There are not a lot of it's extensively used in West Africa. There are thousands of patients. East African, I mean, there's a handful of patients every year. So it's been trialed on 36 patients with East African trips. And they were all local in Malawi. So I think you just need to bear that in mind. does have limitations, but it's a major advance, really, for local settings.
The one thing, excuse me, just regarding the drug is which I didn't realize was the number of drug-drug interactions, particularly the QT prolonging effects. So just up to the minute update on our patient. He's now in the ward. He's doing extremely well. Overwhelming majority of his bloods have returned to normal. The only remaining thing is his renal dysfunction, which is improving. He's still on dialysis, but that's at least a much less intensive dialysis schedule. And his son has already been discharged and is receiving his serum as an outpatient. And the dad hopefully will be discharged within the next few days.
Sure.
So thank you.
So that was excellent.
Yeah,
And
fantastic.
very good care of patients.
Were they on malaria prophylaxis?
Yeah. So they were on doxycycline and still are on doxycycline.
Yeah, you don't want malaria.
And I want to know, did they have travel insurance? Who threw them to you?
That's a very contentious question.
Yeah.
Right? Because,
So the Cayman, so I must say we're quite spoiled most of the time. We have people coming down to us. They're on Bupa or Cigna or one of these big insurance companies based in Geneva. Invariably, unfortunately, with those big companies, there's a 2-day negotiation that some poor family member in Zambia has to speak to someone in an office in Switzerland to try and get them flown out here. These guys, being from the Cayman Islands, the son is on a Cayman insurance. And I don't think there are too many Cayman Island people who travel through sub-Saharan Africa. So he at least was okay. The father, unfortunately, is in between insurance and jobs, but the network. So one thing that's really been quite remarkable about these two cases was the network within the Cayman Islands, the ex-South African network here. As I was buying coffee this morning from the coffee shop at the hospital, one of the oncology MOs said, "Hey, are you looking after those two guys?"
They have so many friends.
Yeah.
And
So I said,
how
and they've been around for a month, these guys. And then I see you all sorts of things. And she said, no, her family and her parents are in Scotland, and these guys know somebody in
they
Scotland.
need everyone.
And really, it's
crowdfunding?
yeah. So it's been a monumental effort. Thankfully, it's nothing that I've got to be involved with. The father had a very hairy first week. He was on one of those awful NIV masks. He was on nanotropes. So after that first dose, it elicits this surge response and this inflammatory response that just the next day everything goes down to single digits. Either single digits or 3 digits. So whatever is supposed to be a single digit is now 3, and whatever's supposed to be 3 is now a single digit. And luckily, we managed to avoid intubation. He needed a few days of nanotropes. He was on continuous dialysis for the first week. And so it's, I must say, the fact that the hospitals in Harare and Lusaka are managing these patients is really amazing.
But the neck played fixed. What the different company?
I'm not sure.
no, you just received.
I'm not sure.
I'm not so sure. So there are major problems with the insurance companies. They do not appreciate the rapid progression of trypanosomiasis. It's much quicker than malaria.
Yeah.
And then sometimes they see, and that's quite an atypical lesion. If you get that on a small picture, it looks like tick bite fever.
yeah.
Why don't you just give them doxycycline? And it is a little atypical. It's got a lot of necrosis rather than the redness with a little bit in the middle.
I mean, the son didn't even have a
No.
dish on.
Well, 80% don't.
Definitely had it, so.
Yeah.
like,
So 80% do, but 20% don't.
He could point to the
Place.
spot on
Yeah.
his leg
Bitten,
where he was
but
bitten.
there was no mark.
But there was,
Yeah.
I mean, I could have manifested a mark if I really tried.
Yeah.
But, you know,
Yeah.
but it wasn't a,
Yeah.
But I really think you and the team did a brilliant job.
Mm.
Emily. Really
they,
brilliant.
yeah, it was,
Think about
thank you. It was, yeah, it was hard work. I must say they're hard work, the patients. But
keep going.
the drug is magic.
Yeah.
But you didn't use the new drug campaign.
No, so
They didn't have secondary.
we didn't have any. We do have some almost now at the airport,
Oh,
but you have to give it orally. So I don't
if
think.
they're out of it.
Well, you can't really secure it. And the other thing is the major advantage is it crosses into the CSF. So if you've got a patient who's really quite ill but not desperate, they don't need a lumbar puncture because it actually crosses.
Yeah.
And it's a major advantage, especially when you're out there being treated in a smaller hospital. Harare has and Visaka have treated a number of really sick patients, and they do a very good job.
With this.
With early diagnosis, they have a lot of experience. They had serum, but it was expired. There's small stock in a couple of places in Southern Africa, but mostly they have to ask the WHO to send it, so there's a delay. But they have good experience.
Okay.
But yeah, I don't know if expired makes any difference.
I would give it a go.
If there's nothing else.
Yeah.
The thing is, it's one thing to give the drug, and I really need to go and visit these places. But it's the next few days
Yeah.
They just crash.
Yeah.
that are just awful.
Yeah.
They crash.
Yeah.
So
So did the father have secondary?
no, so
So-
that's
Well, you
that's-
didn't know. You just had to. But he was comatose. I mean, he was.
so
on
he had
the-
a lot of other reasons to be so encephalopathic, renal dysfunction, liver dysfunction, he's spiking fevers up to 40 degrees. It seemed just in some of the email chains that we've had over the last few weeks that one of the guys in the WHO who deals with this says, in the early few days, there's so many other reasons for somebody to be so agitated and so encephalopathic. But at least now with the newer drugs, we we'll obviously treat all of the other issues, but the sort of second stage, the neurological component, hopefully a lot easier to treat.
But it's
In fact, the father's CSF was better than the son's
Yeah.
in terms of numbers of cells.
So the opinions vary about when to do the CSF. A lot of people say you do it on admission, you know what's happening in the CSF, and you change accordingly. The patients are so sick, can hardly even do a lumbar puncture. And we prefer, and a couple of other people do, just get the parasites down, get them cleared from peripheral blood, stabilize the patient, get your lab ready, and then do the CSF.
Yeah. Also,
If you had to earn milastogrel,
if you're
yeah,
in a hurry, you're more likely to get a bloody tap. And if there's still
you don't know where you are.
strips in your
You don't know where you are.
is it from the blood or is it from the CSF?
Yeah.
It makes sense to clear the blood.
Different. I think the key thing is to get drug in. So get the serum in and just be quite proactive at the beginning. That's we all agree on.
Okay, perfect. So we're just checking the chat. If anyone still has any questions, please pop it into the chat. But otherwise, I don't see any questions coming in at the moment. So thank you so much to Sanofi for providing our snacks for tonight. And just remember that all of our lectures are available on our YouTube channel. So if you've missed any lectures or you've missed one, or you just want to re-listen to us, just make sure to follow Travel Doctor on YouTube, and you can just search Suitcase Club. But